Good morning, everyone. This is 7 a.m. Eastern Standard Time. Welcome to the Orlando GI Journal Club. Our first study is by Lee et al. This was published in JAMA, and this is a pragmatic randomized trial looking at screening for H. pylori to see if this will prevent gastric cancer in Taiwan. Gastric cancer is diagnosed approximately 1 million people each year and causes 800,000 deaths annually. H. pylori is a known contributing factor to the development of gastric cancer, but the effects of screening for H. pylori and gastric cancer incidence and mortality are unknown. So these authors wanted to evaluate the effects of an invitation to screen for H. pylori on gastric cancer incidence and mortality. So this is a pragmatic randomized trial of residents aged 50 to 69 years in Taiwan. And the population that the investigators drew their participants from were people who were eligible for biennial fecal immunochemical testing for colon cancer screening. The investigators randomized patients who qualified for FIT for colon cancer screening to be also invited for H. pylori stool antigen testing along with FIT for colon cancer screening, or the patients underwent just fecal immunochemical testing for colon cancer alone. The median follow-up for H. pylori testing with FIT, that population was 5.7 years. Patients undergoing FIT only were 5.4 years. And the primary outcome measure was the incidence of gastric cancer and gastric cancer mortality during follow-up. The authors identified 269,870 individuals aged 50 to 69 years eligible for FIT in Taiwan in 2014. They divided the group into two, essentially, and 120,000 people were randomized to H. pylori stool antigen with FIT, and 120,000 people were randomized to FIT only. These patients, after excluding those who did not qualify, were then invited to participate in H. pylori stool antigen with FIT versus just FIT only. And in the end, they identified 31,497 participants who underwent H. pylori stool antigen and FIT assessment, and 31,777 participants who underwent FIT testing only. And if you look at the baseline characteristics, this is the table. So as you can see, the mean age in both groups was 58 years. They had more female than males, 58.6% females in the H. pylori with FIT group, and 58.3% females in FIT alone group. When you look at their history of H. pylori infection, 1.2% in the H. pylori stool antigen group versus 0.8% in FIT alone. If you look at the patients who underwent H. pylori stool testing, 12,142 participants tested positive for H. pylori stool antigen. 71% of these patients received antibiotic treatment, and in 91.9%, H. pylori eradication was achieved. This is a table now showing the outcome measures. So we're going to first look at the incidence of gastric cancer among those who were invited. And then this row shows the gastric cancer mortality among those who were invited. If you look at the group that underwent H. pylori screening along with their FIT, the incidence of gastric cancer was 0.317 per 1,000 person years. In the group that had FIT alone, gastric cancer incidence was 0.367 per 1,000 person years. If you look at the rate difference between the two groups, it's minus 0.05. And if you look at the unadjusted risk ratio, this is 0.86 with 95% confidence interval of 0.68 to 1.10. And so this shows that the unadjusted risk ratio, there was no significant difference between the two groups, those who underwent H. pylori screening versus who did not, along with their FIT. Now, the authors also performed post-hoc analyses and calculated an adjusted risk ratio. They adjusted for differences in screening participation, length of follow-up, and patient characteristics. And when they performed an adjusted analysis, they found that the adjusted risk ratio was 0.79 with a 95% confidence interval of 0.63 to 0.98. And this meant that in the adjusted risk ratio analysis, that the incidence of gastric cancer was significantly lower in the H. pylori screening group versus those who did not have H. pylori screening. If you look at the gastric cancer mortality now among those participants who are invited to participate, the rate of gastric, so the incidence of, so the mortality rate essentially was 0.145 in the H. pylori group versus 0.130 in the FIT alone group. The rate difference was 0.015. And if you look at the unadjusted risk ratio again, is 1.12 with a 95% confidence interval 0.77 to 1.62. So again, when you look at the unadjusted risk ratio, there was no significant difference in gastric cancer mortality between the two groups. The authors also performed post-hoc analyses and calculated the adjusted risk ratio, again adjusting for differences in screening participation, length of follow-up, and patient characteristics. Unlike gastric cancer incidence, they found that even with the adjusted risk ratio calculation, there was no significant difference in gastric cancer mortality between the two screening groups. These are the limitations of this study. In total, 240,000 individuals were randomized, and then invitation was sent out. And a significant proportion of participants, 38,792, were unreachable for invitation to participate, which may affect the validity of the results. Only 41.5% of invited participants then underwent testing. Among participants who tested positive for H. pylori, only 71% received treatment, and the differences in baseline characteristics between two groups existed, and there were different lengths of follow-up. Also, a major limitation of this randomized trial is the relatively short follow-up, and that may have reduced the ability to identify differences in rates of gastric cancer incidence and gastric cancer mortality. The take-home point from this randomized trial is that among residents of Taiwan, an invitation to test for H. pylori stool antigen combined with FIT did not reduce rates of gastric cancer or gastric cancer mortality compared with invitation for FIT alone. However, when differences in screening participation and length of follow-up were accounted for, gastric cancer incidence, but not gastric cancer mortality, was lower in H. pylori stool antigen with the FIT group compared to FIT alone. Our next randomized trial is published in CGH by Carleen et al. This is looking at the efficacy of Tradipitant in patients with gastroparesis, and this was a phase 3 randomized placebo-controlled clinical trial. Currently, the only FDA-approved medication in the United States for diabetic gastroparesis is metoclopramide, which is restricted to a 3-month duration due to risk of neurological side effects. The neurokinin receptor 1 binds substance P, which is located in gastric neuromuscular junction and is thought to stimulate smooth muscle contractions. Also, the receptors are located in the central nervous system with a key role within central emetic circuitry. The neurokinin receptor 1 antagonist, Tradipitant, has been shown to be effective in reducing nausea and vomiting in chemotherapy-induced emesis. So the aim of this study was to evaluate the safety and efficacy of Tradipitant in patients with idiopathic and diabetic gastroparesis. This was a randomized trial. This was performed across 46 sites in the United States. It's placebo-controlled, double-blinded. The participants were patients aged 18 to 70 years with idiopathic or diabetic gastroparesis. Patients randomized into two groups. They either received Tradipitant at dose of 85 milligrams PO BID for 12 weeks versus placebo. The primary outcome was change from baseline to week 12 in the average nausea severity, measured using the gastroparesis core symptom daily diary, GCS-DD. In total, 102 patients were enrolled in were randomized to Tradipitant. 99 patients were randomized to placebo. 75% of patients in the Tradipitant were female, 84.8% in the placebo group were female. The mean age was 49.5 years in Tradipitant group, 48.8 years in placebo group. The etiology of gastroparesis were fairly evenly split. 51% had idiopathic gastroparesis, 48.8% had diabetic gastroparesis. If you look at the BMI, mean was 30. The authors then looked at the overall gastroparesis symptoms, and between Tradipitant and placebo by week 12, there was no significant difference in terms of improvement in nausea between Tradipitant and placebo groups. When they looked at also the GCSI total score, there again was no significant difference between the two groups at week 12. Looking at other measures, looking at PGI and OPBS, there's also no significant difference between the two groups. Now, the authors also wanted to see if there was any difference in symptoms depending on the drug levels and pharmacokinetics. So they compared the patients who were enrolled or randomized to Tradipitant who had high levels of Tradipitant versus placebo. And what they found was that if you look at week 2 and 4, there was a significant difference between Tradipitant and placebo, with significant improvement in nausea with Tradipitant at weeks 2 and 4 compared to placebo. However, this difference really was not significant at week 12. If you look at other measures, namely nausea-free days, at week 2, Tradipitant showed an improvement in symptoms. Again, if you look at GCSI total scores at week 2 and 4, not necessarily week 12. And again, for PGI and OPBS, there was difference seen at week 2 and 4, but not at week 12 for really any of these measures, even in the high drug level group. These are the adverse events encountered. 49% of patients in the Tradipitant group reported adverse events. 47.5% in the placebo group also reported adverse events. If you look at the severity of adverse events, the most common adverse events were diarrhea, nausea, abdominal pain, dizziness, headaches, and fatigue, and diarrhea really being the most common symptom, seen in 9.8% in the Tradipitant group versus 2% reported in the placebo group. If you look at the severity of adverse events, severe adverse events reported in 3.9% of Tradipitant versus 3.0% of placebo. I think what this study shows is that gastroparesis really is a very difficult and challenging condition to manage. And if you look at this medication, Tradipitant, it did not reach significance for improvement in gastroparesis symptoms in their intention to treat analysis, which was following up symptom differences at week 12. But they do note that pharmacokinetic exposure response analysis demonstrated significant effects with adequate Tradipitant exposure, especially at weeks 2 and 4, suggesting that it does have potential as a treatment for nausea in gastroparesis. So definitely something to keep in mind. Our next study is by Garcia et al. This is published in the American Journal of Gastroenterology. This is looking at the persistence, effectiveness, and safety of Upadacitinib in Crohn's disease and ulcerative colitis in real life, and this is a Spanish nationwide study. There is a constant need to find new therapeutic agents for IBD, and Upadacitinib is an orally administered selective reversible inhibitor of JAK1 that downregulates multiple pro-inflammatory cytokines involved in pathogenesis of Crohn's disease and ulcerative colitis. Randomized trials have demonstrated Upadacitinib superiority over placebo in inducing and maintaining remission in patients with active Crohn's and ulcerative colitis, in naive patients and those refractory to previous biological agents. However, real-world data on effectiveness of Upadacitinib for IBD are limited. The aim of this study was to assess the Upadacitinib persistence, and that essentially means the duration over which patients remain in a specific treatment, the effectiveness and safety in a real-world scenario. This was a retrospective multi-center study from Spain. The authors enrolled patients with IBD at least 18 years of age who received Upadacitinib for 12 weeks prior to recruitment. They identified 100 patients with IBD, 68 with Crohn's, and 32 patients with UC who had received median of 4 advanced therapies previously, and the median follow-up was 7.6 months. So a total of 100 patients were enrolled, as stated previously. 68 patients had Crohn's, 32 patients had ulcerative colitis. In total, the proportion of male patients was 57%. The median age was 48. The median time to follow-up was 5.7 months, ranging from 3.4 to 10 months, and that was the interquartile range. The median time for IBD diagnosis was 11 years, 6.1 to 20, with the interquartile range. In terms of smoking, 50% had never smoked, and 18% were current smokers. 44 patients had undergone prior surgeries. When looking at the location of ulcerative colitis, extensive colitis seen in 63%. For Crohn's disease and location, the majority of patients had ileal disease followed by ileocolonic disease. And 13% had upper location affected with Crohn's, and 13% had Crohn's affecting the colon only. Perianal disease was seen in 23%. 62% of patients had immune-mediated diseases or extraintestinal manifestations. 83% had received prior treatment with immunomodulators, and that included advanced therapies being administered in 97% of the patients. 75% had undergone prior treatment with anti-TNFs, 89% of vedolizumab, and 26% with ustekinumab. 22% patients were receiving steroids at baseline, and the number of previous advanced therapies was a median of 4 in the quartile range of 3 to 5. Now, looking at persistence, so the ability of a patient to remain within a given treatment, 23 patients had discontinued treatment out of the 100. And when looking at factors associated with treatment discontinuation, they found that Crohn's and age less than 40 years was significantly associated with treatment discontinuation. And Crohn's had a hazard ratio of 3.7, and age less than 40 years as a factor had a hazard ratio of 2.4. Looking at clinical remission, this is a graph just showing the patients who had a clinical remission, and this is this is time in weeks in the x-axis. Now, if you look at clinical remission, which essentially is this gray bar in the middle, at 4 weeks, 51% seemed to be in clinical remission. At week 8, 59%, at week 12, 64%, and then gradually decreasing over time, 53% at 26 weeks and 42% at 52 weeks. Now, proportion of patients with UC who previously were exposed to upadacitinib were 25 patients in total. They achieved clinical remission and was 78% at week 12 and 50% at week 52. Factors associated with clinical remission at week 12 were having UC, mild or moderate activity at baseline, and not smoking. This is a breakdown of patients with immune-mediated diseases or extraintestinal manifestations. 80% of patients in the study with active immune-mediated diseases or extraintestinal manifestations improved with upadacitinib. And this is the list of these manifestations at the start of upadacitinib treatment. And as you can see, this is the report of progression during upadacitinib treatment. And peripheral arthritis seemed to be in remission or improved in 60%. Axial spondyloarthropathy remission achieved in 20%, improvement in 47%. Psoriatic arthritis improved in the one patient who had it. For rheumatoid arthritis, improvement was noted in 43%, and remission in 43%. PSC, remission in 50%. Erythema nodosum and skin psoriasis in the one patient in those two groups, remission was achieved. These are the adverse events encountered with upadacitinib treatment. The most common adverse event reported was infection, which was seen in 15%, anemia, followed by anemia 10%, and hypercholesterolemia 8%. The limitation of this study is that this is a retrospective study with relatively small number of patients. In fact, only 32 patients had ulcerative colitis. Also, because this is a retrospective study in a real-life situation rather than it being in a randomized trial, there was no predefined protocol for patient management, and lab tests were not routinely performed. So the way the patient was managed in terms of visits and follow-up were conducted per the expertise of individual doctors taking care of these patients. And then finally, mucosa evaluation by endoscopy during follow-up was lacking in the majority of patients. Again, this being a real-life retrospective study with the less stringent criteria that you would see in a randomized trial. The take-home point from this study is that upadacitinib is effective in treating Crohn's and ulcerative colitis in real-world scenario, even in a highly refractory population and in patients previously exposed to JAK inhibitors. Upadacitinib reduces inflammatory activity associated with immune-mediated diseases and extraintestinal manifestations in IBD and has an acceptable safety profile. To recap, among patients, among residents of Taiwan, an invitation to test for H. pylori stool antigen combined with FIT did not reduce rates of gastric cancer or gastric cancer mortality compared with invitation for FIT alone. However, when differences in screening participation and length of follow-up were accounted for, gastric cancer incidence, but not gastric cancer mortality, was lower in H. pylori stool antigen FIT group compared with FIT alone. Tradipitant did not reach significance for improvement in gastroparesis symptoms in intention to treat analysis, a 12-week follow-up. However, pharmacokinetic exposure response analysis demonstrated significant effects with adequate Tradipitant exposure, suggesting Tradipitant has potential as a treatment for nausea and gastroparesis. Upadacitinib is effective in treating Crohn's and ulcerative colitis in a real-world scenario, even in a highly refractory population and in patients previously exposed to JAK inhibitors. Upadacitinib reduces inflammatory activity associated with immune-mediated diseases and extraintestinal manifestations in IBD and has an acceptable safety profile. Thank you so much for joining me in this month for our monthly Orlando GI Journal Club. The first Wednesday of 2025 is actually January 1st. So we will reconvene on January 8th, which is the following Wednesday, just for January. And then we'll continue with the first Wednesday of each month going forward. Thank you so much again for joining me. Hope you have a wonderful day, week, and month. Happy New Year, happy holidays. Please stay safe and take care. Thank you so much. Goodbye.